Good afternoon. Can you hear me? My name is Thomas Cope. I'm from Cambridge. It's a huge pleasure to introduce this year's JNNP lecture, which is Professor Ed Bullmore, who's a colleague. So Professor Bullmore graduated from Oxford and St. Bart's, and then after a brief stint in Hong Kong lecturing, did his psychiatry training in London, doing a PhD in neuroimaging analysis, and he's been really a world leader in the development of graph theory, which has been a hugely influential technique in imaging analysis. But more recently, Ed has published an incredibly successful book on the interplay between inflammation and depression, which has been the #1 bestseller in the Kindle store in psychiatry this year. So Ed's going to talk to us about this topic, and I'm really looking forward to it.
Well, Thomas, thanks very much for that introduction, and it's really a great pleasure to be here for the BNPA meeting. I remember the BNPA forming with Alwyn Lishman as the founder-president, and it's always struck me as a very important organization, and I'm delighted to be here to play a part in this meeting. I'm going to talk about inflamed depression. And as you can see straight away, I work half-time for the University of Cambridge, and I currently still work half-time for GlaxoSmithKline. So you might want to bear that in mind as I go along, that I do have that industrial affiliation. But as Thomas said, what I really want to talk about today is the ideas in the book, The Inflamed Mind. And I'm sure everybody's read the book very carefully. But for those of you that might not have read the book, let me, at the risk of spoiling the suspense of the whole thing, I'll tell you what the final few sentences are. We could be on the cusp of a revolution. It won't be televised, and I might be wrong, but I think it has already begun. Now, that might all sound a bit cryptic at this stage. Hopefully, it'll make a bit more sense by the time I get to the end of this talk. The one thought that I would ask you to bear in mind is this one: I might be wrong. And the book is not written because I think this is all done and dusted and it's time for a kind of popular textbook of facts. There are some, I think, solid facts that have emerged from the science that I'll be talking about, but I think it's also an exciting area of science precisely because not everything yet is cut and dried. It's, I think, a science at an inflection point. It's been growing for some decades, quite quietly in the background, with a sort of pulse of extra energy and investment coming into the field just recently. And I think there are some very exciting prospects ahead, but it is at an inflection point. It's not yet a plateau. Some of what I will be saying is a matter of fact, I would claim, and some of it is going to be a bit more speculative and a bit more future orientated. Now, I'd never written a book like this before, and I was very excited to discover that actually I could rattle off words quite quickly. And I produced a sort of first draft of about 50,000 pages. I thought, that's pretty good. I'm a little bit worried I might have dumbed it down too far, but overall I thought that was, I was pretty pleased with it. I sent it off to the publisher, and then we had a little conversation. She's a very charming person, but she did let slip, you know, nobody's ever going to read this. It's far too dense. It's far too technical. And I discovered over the course of rewriting it that what she thought was important, and I think it is important if you're trying to write something that's going to reach people, is stories. So she said, tell stories. And some of those stories are about me. So I ended up putting more of myself into the book than I would, you know, ever dream of putting into a scientific paper or a scientific review. But one of the stories I start with is what I ended up calling my Molière moment at the Maudsley. So some of you in the room will remember roughly what happened in the Maudsley at around about the time I'm talking, in 1990. The Maudsley was the epicenter for psychiatric training in the UK. And I didn't get in there the first time I applied, but I kept going, and eventually I made it, and there I am. Age 30 at the Maudsley, looking, as you can see, a little bit pleased with myself. And, you know, I started work on the MRC psych examination. I started reading about neurotransmitters and psychopharmacology and so on, and quite quickly began to think, you know, I'm actually pretty good at this. until I met a man who came into the outpatient clinic one day and he said, I'm feeling gloomy about the future, guilty about the past, I'm not sleeping like I used to, I've lost interest in sex, nothing seems to give me pleasure anymore. And I said, after due deliberation, I said, you know what, I think you might be depressed. And he was depressed, but he was very unimpressed with that diagnosis. He said, look, I know I'm depressed. That's why I asked my GP to refer me to your clinic. The question is, what are you going to do about it? So I started talking about these rather sort of exciting new drugs that had just been launched, Prozac being one of them, the so-called selective serotonin reuptake inhibitors, SSRIs. At the time, pretty buzzy, everybody's thinking that was a new frontier. And I was saying, well, we can give you this drug, it'll boost your serotonin levels, that might sort of sort out the transmitter imbalance in your brain and will make you less depressed. And he said, how do you know that? And I said, well, I've just read about it actually in the textbook I'm studying, and that's the serotonin theory of depression. And he cut me off. He said, now, how do you know that about me? How do you know that the serotonin levels in my brain are low, and that by giving me this drug, you're really going to boost them back to normal levels? A very penetrating question. We looked at each other in the eye for a microsecond and both realized I had no answer to that question. Actually, still, none of us has a good answer to that question, I would say. So it was a moment, and he left with a prescription and an appointment to come back in 6 weeks' time. But he also did leave me feeling a bit of a fraud, a bit like one of Moliere's old 18th century physicians, using sort of exotic language, claiming to understand perhaps more than I really did about what was causing his depression and why a particular treatment was indicated. Now, if I jump forward from 1990 to where we are now and think about depression and what we've got in terms of treatment, I think one thing that is clear is that the drugs that we have are better than sugar pills. They are effective, significantly effective. They're moderately effective compared to placebo. If you look at this meta-analysis that Cipriani and colleagues published early last year, you can see each one of these drugs listed here has a meta-analytic effect size based on analysis of, I think, all published and unpublished clinical trial data. You can see each of these intervals needs to be distinct from this vertical line for there to be a significant effect in favor of active treatment, and that is true for all of them. So we have, in fact, got a large number of moderately effective antidepressant drugs. But there are still, I think, a number of significant problems. We still don't have a good answer to the question that patient asked me nearly 30 years ago. We don't know in any particular patient that serotonin levels are at low levels, and we therefore perhaps don't have very good ways of predicting which patients are most likely to respond or not respond to any particular antidepressant drug. Treatment often follows a sort of slightly circuitous process of trial and error to arrive at an effective combination of treatments in an individual case. And there's been very little therapeutic progress. If there had been therapeutic progress, then this drug at the top with the biggest effect size compared to placebo would be the newest drug, and this drug at the bottom with the smallest effect size would be the oldest drug. But many of you recognize immediately that amitriptyline is pretty much the oldest antidepressant we've got. That predates Prozac and the SSRIs by about 30 years. So it is not the case that the more recent medication available to us is the most effective medication. It doesn't seem to be particularly progressive. Moreover, almost all of these drugs are in some way or another targeting the same basic mechanisms, monoaminergic mechanisms, serotonin, noradrenaline, that have been at the heart of pharmaceutical and psychopharmacological thinking about depression for, the whole of my life, 50, 60 years. That's been the dominant model. And yet, despite the fact that we've got these drugs that are moderately effective on average, we all know that there are many patients, perhaps a third, that don't respond. And that if you look at the sort of epidemiological data, the public health data, depression is on course to become the single biggest cause of disability in the world in the next few years. So huge levels of unmet need. despite existing treatments. And in a perfect market economy, you would think that demand for new treatments would stimulate investment to discover new treatments. The market should respond to demand by increasing the capacity for supply. But actually, industry investment in R&D for depression and many other mental health disorders has declined, particularly since 2010. And I mentioned that I worked for GSK, I still do. In 2010, this came home to me in a very direct way. We were summoned with some urgency to a teleconference, and the head of R&D at the time got on the call and said, we are strategically exiting psychiatry. We're going to close the whole of the psychiatry R&D centre, a couple of sites, one in this country, one in Italy. Many hundreds of people were made redundant, many programs were closed. It was a complete annihilation of that particular therapeutic area. And about 6 weeks later, rather sheepishly, I went back to my boss and I said, look, you know, I'm a psychiatrist. The company doesn't seem to want to do psychiatry. I mean, is there any future at all? Can you imagine any way that we might want to get back into antidepressant drug development? And he said, well, I'll never say never, but if we were going to do antidepressant drug development again, it would have to be completely different to the way we did it in the past. And that really got me thinking quite hard. How could you take a completely different approach that would circumvent or sidestep some of the problems that had bedeviled the more traditional model of antidepressant drug development? And that in turn got me thinking seriously about immunopsychiatry, the possibility that immunological mechanisms might be relevant to mental health and could represent a new approach therapeutically. Now, I'm sure many of you in the room are reasonably well versed in immunology, so forgive these slightly cartoonish diagrams, but I have discovered, talking to general audiences, that most people know where the nervous system is. I mean, it's 90-something% of it is in your head, it's in your skull, but people are generally rather vague about what the immune system is, where it is, what it does. So in the book, I talk about this scenario as an exemplar. You know, many hundreds of thousands of years ago, a couple of our ancestors were having a fight. One of them was injured. The blade punctured the skin. The blade was contaminated with bacteria. There wasn't a traumatic infection of the hand. And he, the caveman, I mean, will have noticed a few days later that that wound became inflamed, to use a word that he probably wouldn't have used at the time. But it became swollen, it became red, it became tender. He lost function in that hand. So we've known for a long time, in fact, arguably back to the Romans, that infection trauma tends to cause this inflammatory response. What we now know is much more detail about how that happens and why it happens. We know that these bacteria that are contaminating the blade are detected as a threat to the self, as a threat ultimately to the survival of the organism, and the immune system is on the case and immediately trying to deal with it. These little emojis are representing the macrophages, the innate immune system cells that sit like sentinels everywhere in the body as a first line of defense against infection. And they eat bacteria, they digest and destroy bacteria. They also produce a number of inflammatory hormones or cytokines, shown here by this little sort of exclamation mark signal. And the cytokines get out into the circulation and, amongst other things, attract more macrophages out of the blood to join in the defense, to reinforce the defense against this local infection. So I think one thing that's quite an important concept and I've found is a bit of a sort of learning point for general readers of the book, is that although the clinical signs of infection might be rather localized, even a local inflammatory response like this, or what appears local superficially, is accompanied by these systemic changes, the circulation of cytokines, the recruitment of other cells from the rest of the nervous system. And of course, if you get into the detail of the immune system, it is mind-bogglingly complex. I mean, I did MRCP before I started in psychiatry, so I'd got to that level of clinical immunology by the end of the 1980s. And I didn't really look at it again until about 2011, 2012, when I was thinking about antidepressant drug development. And I was amazed how much had changed in immunology in the intervening period, how much more detail there was available, how much more precisely everything was understood mechanistically. There were concepts, important concepts that had really not been part of the teaching when I last attended to it. And what we now know, of course, it's a very distributed system. It's not located all in one place like the brain. It's in the spleen, it's in the bone marrow, it's in the lymph nodes. You can think of it, it's quite interesting to imagine what the body looks like from the immune system's point of view, which is what I'm trying to show here. There's this front line, if you will, the boundary between the self and the non-self, which is what the immune system is defending with these macrophages located throughout the body system, teeth, gut, hand, brain. Everywhere in the body there are macrophages. They can detect infection and deal with it to some extent on their own terms, but they also move around. They migrate into the lymph nodes, the so-called command and control centers, bringing information about the antigenic material that they've encountered on the front line, and that instructs lymphocytes and other cells to produce antibodies and other humoral components of the immune system, all of which will reinforce the response initiated by the macrophages. It's a very complex, clever system. I've said it before, but I mean, we often like to sort of brag about the brain or the nervous system being the most complex system in the universe. I've always had a worry about that claim because I'm not sure who's measured the complexity of every object in the universe and would know that the human brain happened to be at the pinnacle. But I honestly think, even if you don't look in the universe, you just look in the body, it's debatable what's the more complex system. Is it the nervous system, or is it in fact the immune system? Now, the association between inflammation and depression, I would again dare say, is common knowledge to us all. We've either all had some personal experience of depressive mood changes or possibly even a major depressive episode coupled in some way to infection or inflammation. And even if we haven't, I would be surprised if there were many practicing clinicians in the room who hadn't once or twice met a patient like this. In the book, I call her Mrs. P. She's a middle-aged woman with arthritis that I saw in a medical outpatient clinic around about the end of the 1980s, so just before I started at Maudsley. And of course, we spent a lot of time talking about her deformities, the joint swelling, the rheumatoid nodules that she had just above her elbow, all the sort of classical signs and symptoms of rheumatoid arthritis in the body. But I noticed that she was looking a bit like this, and I started asking her how she was feeling, and sure enough, she quietly but very unmistakably told me that she was lacking in energy. She was finding it difficult to get going in the morning, difficult to concentrate and plan her future very clearly. She felt guilty about events in the past. She was losing pleasure in life. And again, I came to the conclusion that she was depressed. And for some reason, I remember being quite pleased with that. I thought I'd done a bit of a sort of diagnostic double take. You know, she'd come into the clinic with rheumatoid arthritis, and I'd incisively recognized that she also had a depressive disorder. And I went to the consultant in charge of the case and said that I'd made this enormous discovery. And he looked at me and said, well, she's depressed, but you would be, wouldn't you? And that was it. Changed the subject. And Mrs. P left the outpatient clinic in exactly the same state of mind as she'd arrived. And I think about that very, very succinct statement, you would be, wouldn't you? And I think that there's an awful lot buried under that. I think what he meant, if he'd spelt it out in longhand, if you will, is that, yes, she's depressed, but she's depressed not because of her arthritis, not because she's inflamed, but because she knows she's got arthritis. She knows that that's a chronic progressive illness. She knows that over time her mobility is likely to deteriorate and that treatment is likely to be ineffective. She's looking at a very gloomy prognosis, and she's rationally reacting to that, psychologically reacting to that in a way that makes her depressed. It's a surprisingly complicated explanation for a very common coincidence. And Dinesh was talking a moment ago about Cartesian dualism, and I think that's an example of Cartesian dualism. I think that physician, the consultant physician I consulted, was very clear that her physical illness really couldn't be directly related to her mental state. It had to be explained in this sort of rather roundabout way, which assumes, as Descartes did, that each of us is a deus ex machina, a god in the machine. There is a mechanical, physical element to our existence. The muscles, the eyes, some of the nerve cells all behave according to the laws of physics in a rather mechanical way. And then there is a mysterious interface with an immaterial component, which actually in Descartes' original thinking was the soul. It was a divine spark, if you will, but we've inherited that as the psyche or the mind. And we've inherited the idea that there's something qualitatively very different about body and mind. The two are quite apart. And that, I think, is one of the more fundamental, if unspoken, reasons why it's so easy to say, well, you would be, wouldn't you? It's not that Mrs. P's experience is uncommon. You know, there are lots of patients with chronic inflammatory disease who have symptoms of depression, fatigue, poor concentration. They often call it brain fog. You know, the rheumatoid arthritis charities and other service user representative groups run surveys on unmet need amongst patients, and these psychological symptoms consistently come top. These are data I'll come back to in a slightly different perspective later. These are clinical trial data. These are patients who were recruited into phase 2 or phase 3 clinical trials for anti-inflammatory drugs targeting non-psychiatric inflammatory disease, inflammatory bowel disease, psoriasis, asthma, rheumatoid arthritis, and so on. And one simple point is that even in a clinical trial population, which, remember, is going to be a slightly sort of cleaner version of the real disease population, you can see there are high levels of depressive symptoms. I mean, the rate amongst rheumatoid arthritis patients in particular is very high. In excess of 25% of those patients had significant depressive symptoms. You can also see that those depressive symptoms, the percentage of patients with depressive symptoms, it correlates significantly with the mean baseline levels of C-reactive protein. So the more inflamed you are at baseline, broadly speaking, the more likely you are to be depressed. It's a very consistent association. Not that any of these patients would have a diagnosis of major depressive disorder, because another manifestation of dualism, I would suggest, is this, the sting in the tail of DSM-5 criteria for MDD. I looked at these quite carefully the other night. This is the formal algorithm that we go through to make a diagnosis of major depressive disorder. It is striking, to my mind, how non-specific some of this is. Insomnia or hyposomnia, psychomotor retardation or agitation, any kind of change of weight or appetite. A lot of this is very inclusive, but you're excluded if the episode is attributable to a substance or medical condition. So by definition, somebody like Mrs. P cannot have major depressive disorder. We might call her comorbid depression, but nosologically there is a Cartesian divide running through the middle of depression. What if we look not at the sort of comorbid side, but at the, if you will, true bill psychiatric MDD side of it? What's the evidence for an association with inflammation in major depressive disorder? And these are, again, meta-analytic results summarizing about a 20-year history of case control studies of depression, where people have found a group of patients with depression, a group of healthy controls, taken a blood sample and measured inflammatory proteins. You can see here the forest plot shows that the effect size, the difference between cases and controls in inflammatory proteins, has actually remained pretty stable over time. The confidence interval has narrowed as the total number of participants included in this analysis has increased. So we now have a moderately increased value for interleukin-6, one of the key pro-inflammatory cytokines in circulation, a standardized effect of about 0.5, and a very narrow confidence interval. It's difficult to imagine how future studies are really going to shift that result. So I would say that's a fact, that IL-6 is increased on average in major depressive disorder. It's a similar story for C-reactive protein, which is in fact not that surprising because IL-6, amongst its many other actions, drives or induces the synthesis of C-reactive protein. TNF-alpha, another pro-inflammatory cytokine, also significantly increased. Not everything's increased. IL-1 beta is another pro-inflammatory cytokine that is not significantly changed in depression. So I would say that's very robust evidence for some level of association in MDD between inflammation measurable in a blood test and the existence of the disorder. But nothing I've told you yet gets at the crucial question of causality. And this, I've discovered, is the mountain that one has to climb to overcome what might be Cartesian skepticism about a relationship between the immune system and the nervous system or mood. People will say, okay, yes, they're correlated, yes, they commonly co-occur, but prove to me that it's causal. And that, of course, is quite a deep and turns out to be multi-headed question. How do we establish the causality of a relationship that we suspect based on clinical association? Well, one way we can start is by thinking about time. We know that in general cause precedes effect. So if we could find evidence that inflammation preceded depression, that would satisfy what you might call a necessary condition for causality. And indeed, there is evidence for that at multiple different scales of time. So, I put in the book, it's another anecdote, I experienced of going for a typhoid vaccination. We were going on holiday, I went for a typhoid vaccination. The nurse said, you might want to think about taking tomorrow off work, it's going to make you feel a bit down. I said, why? She said, that's just the body's way of getting over things. But she was right. I mean, she didn't have a very good explanation for it, but she was right. I didn't feel that great the next day. And that's an example of a sort of low-grade inflammatory stimulus causing a blip, a temporary moment of depressive symptoms. Over a slightly longer time scale, the natural experiment, if you will, of interferon treatment for hepatitis has proved quite revealing. Patients with hepatitis have been treated in the past, not so much in the future, but historically. An important treatment for hepatitis was interferon, which is a pro-inflammatory cytokine. You're basically pumping up the immune system and trying to make it more aggressive in seeking out and destroying the hepatitis virus. But a corollary of that treatment is that for many patients, about 6 or 7 weeks later, they will become severely depressed. Even over a longer time frame, we can see evidence for inflammation preceding depression. And this is data from the ULSPAC cohort, a birth cohort from the southwest of England. The kids in the cohort were all tested for IL-6, interleukin-6, the pro-inflammatory cytokine, at the age of 9, and then assessed for depression 9 years later at the age of 18. And you can see, I think, a very clear dose-response relationship, if you will. If your IL-6 level was in the bottom third of the distribution at the age of 9, your risk of being depressed at the age of 18 is significantly reduced compared to those children who had IL-6 levels in the top third of the distribution at the age of 9. So the temporal data, the time resolved data, are compatible with causality. They show us that inflammation in a non-depressed 9-year-old can predict increased risk of depression 9 years later, or that a typhoid vaccination in a non-depressed adult can cause a momentary blip of depressive symptoms in the following 24 hours. In each case, inflammation precedes depression, inflammation could cause depression. But that in itself is not enough to satisfy our hunger for a causal explanation. To be more convinced about causality, we need to understand not just temporal precedence, we need to understand something about the biological mechanistic chain of cause and effect that links inflammation of the body to depression in the mind. And I think one reason that, when I was talking to my consultant about Mrs. P, that we so quickly sort of agreed with each other that, well, you would be, wouldn't you, was because at the time it was impossible to imagine how cytokines, inflammatory cells in the circulation could have anything to do with the brain and the mind, because we had been taught as I'm sure many in this room were taught at medical school, the brain is immune privileged. Nothing in the immune system touches the brain unless there's some catastrophe like a stroke or a tumour, because there's a blood-brain barrier, a bit like the Berlin Wall, which prevents these proteins and cells in the circulation from getting into the brain. So any explanation we might want to make for depression has to be based on, for example, neurotransmitter imbalance or possibly circuit imbalance at a slightly larger scale of resolution. But the blood-brain barrier prevented us in some ways. You could think of it as a very concrete metaphor, compatible with the old Cartesian idea. It prevented us from thinking that there could be a meaningful communication between the peripheral immune system and the central nervous system. But that was in 1989, and of course since then the Berlin Wall has fallen in Berlin, but arguably also certainly the Berlin Wall concept of the blood-brain barrier has changed substantially. So we now know there are many channels of communication by which inflammatory proteins and even immune cells can get from the periphery into the brain. And when those inflammatory signals reach the brain, and we know this mostly from animal experiments, I should say, when those inflammatory signals reach the brain, one of the things they will do is activate the brain's own immune cells, the macrophages that sit in the brain, called microglia, will become activated in response to a peripheral inflammatory signal. They will pump out cytokines and other inflammatory proteins, and so increase the sort of inflammatory milieu in which the nerve cells are embedded. And we know that nerve cells exposed to pro-inflammatory cytokines will often show adverse changes in function. They will be more inclined to programmed cell death. They will show less evidence of synaptic plasticity. They may also alter the expression of serotonin metabolic enzymes, serotonin transporters, in a way which is compatible with reducing availability of serotonin in the synapse, all as a result of inflammation, and that, of course, could cascade up through the large-scale circuitry to cause depression. That's the different kind of idea that we can begin to explore. And this is a nice example of how we have been already able to do some of that. This is work from Neil Harrison. Some of you may know, was at Brighton, has just moved to Cardiff. And he used this experimental paradigm, the emotional faces. And we know, based on decades of work, that if you look at faces representing, say, sadness, you are more likely to feel a bit sad yourself. Looking at an emotional face induces the same subjective emotional state to some extent. We also know that looking at emotional faces tends to induce activation of relevant brain centers. So in Neil's experiment, he had them looking at sad faces, particularly in a scanner, and was able to show that there was activation of the centers that we'd expect, the amygdala, the cingulate, this is the subgenual cingulate particularly, were activated in response to this emotional stimulus. Now, the interesting bit of the experiment was he did that twice, once after a placebo injection and once after a typhoid vaccination in healthy volunteers, and showed that the more depressed you were after the vaccination, the greater the brain functional change measured by fMRI. And the more evidence there was for disrupted functional connectivity of the cingulate cortex, the greater the levels of plasma cytokines induced by the vaccination. So this is an example of an experimental medicine study using imaging and beginning to build the link, beginning to show how a peripheral inflammatory stimulus that causes increases in cytokines in the blood can also cause changes in activation of brain emotional processing centers that are associated with the inflammation-related changes in mood. So there's much more that I could say about that question of how inflammation causes depression. And as I've already hinted at, a lot of it is still based on animal research. But I'm going to assume that you're happy now, that you're content, that we have some reason to think that inflammation can cause depression. One of the next questions you might have is what causes the inflammation that causes depression? And of course that's characteristic of all causal explanations. They all are at risk of this problem of infinite regress. Well, there are many factors, in fact, that could cause inflammation. There are all the inflammatory disorders that I've already mentioned, that are associated with quote-unquote comorbid depression. And one of the things that we know has happened over the last 20, 30 years is that the scope of immunology and the importance of inflammation has become much more extensive across the whole of medicine than it was. Many disorders have an inflammatory component that we didn't recognize 20 or 30 years ago. So that's a very common potential cause of inflammation that we know is linked to depression. But what if you're talking about a patient who has major depressive disorder? By definition, you don't think there's a significant physical illness. What bodily factors could be driving low-grade inflammation? Not enough to amount to a physical medical diagnosis of inflammatory disease, but perhaps enough to bias neuronal function and circuits in the direction of depressive experiences and behaviors. Well, of course, there are many such biological factors. Obesity is a particularly clear-cut example. Higher BMI very predictably causes increase in CRP, IL-6, and many other inflammatory cytokines. The microbiome, a lot of interest in that. We've got a gut full of antigenic material. If you change your diet, you're going to change the composition of the microbiome. That might look like an infection. It might look like a challenge to the self through the prism of the immune cells lining the gut. Maybe that's a mechanism by which we can begin to think how diet changes microbiome, causes a different kind of inflammatory response in the gut, which in turn leads to changes in mood and behavior. A lot of interest in that. Another possibility, chronic periodontitis. This is, I'm going to spare you the gory details, but in the book I put in a few anecdotes about my own experience here. Chronic gum disease, interesting example of low-grade inflammation because it tends to be neglected, particularly in its relationship to mental health. Dentists will look at teeth and gums, doctors generally not, psychiatrists almost never, and dentists by and large aren't going to spend too much time chatting about mental state. So that's a possible source of inflammation that may not be recognized. There's data out there showing that postmenopausal women have increased levels of inflammation, increased inflammation as we age. The seasonal cycle of light is related to inflammation. There's a very nice paper from John Todd, an old colleague of mine from Cambridge, showing that in the winter months, IL-6 levels increase and decrease during the summer months. And you see that obviously with peaking levels of cytokines in January, February in the northern hemisphere and the reverse cycle in the southern hemisphere. So many bodily factors, biological factors, physical factors, but from the point of view of psychiatry, I think one of the most exciting things about this literature is how it allows us to think a little bit differently about the role of stress. I mean, there is no doubt that stress is the biggest single risk factor for depression. But how does stress cause depression? And part of the answer might be that stress can cause inflammation. And again, in the literature, there's evidence for an inflammatory response to major adverse life events like bereavement or caring for an elderly relative. Childhood adversity, I think, is a very interesting area for further investigation. How does exposure to abuse, adversity, extreme poverty in childhood, how does that carry forward into adult life and confer an increased risk for mental health? Could it be that the immune system has something to do with it? We certainly know the immune system has a memory, because that's how vaccination works. Could it have a memory for social threat as well as biological threat? Could that be part of the relationship between childhood adversity and much later mental health disorders? And there are much more trivial stresses that can cause inflammation. I mean, there's a situation I'm in right now, which is public speaking. Generally, that is a stressful experience. And if you look at that experimentally, there's some interesting evidence for how an acute stress like this can cause inflammation and may compound inflammation due to more chronic stresses. So these are data based on a study of teachers, a notoriously stressful occupation. So you've got a group of so-called burnt-out teachers who feel that they're putting a lot more into their job than they're getting back in terms of reward. They're feeling a bit dissatisfied generally. And then you've got a resilient group of teachers more buoyant about the relationship between the effort they're putting in and the reward they're getting out of the job. So they took these two groups of teachers, they took them into the lab, they took a blood sample, they took the circulating macrophages or monocytes out of the blood, put them in a dish, exposed them to a bit of bacterial antigen, and measured the amount of interleukin-6 they produced in vitro. And they discovered that the burnt-out teachers had circulating monocytes that were producing significantly larger amounts of inflammatory cytokine in response to this lab challenge. You know, they had, if you will, angrier macrophages in circulation, more primed to respond aggressively to an antigenic stimulus. And then the investigators did something a little bit wicked, which is they superimposed this, the triosocial stress test, a kind of experimental model of public speaking. The participant stands in front of this sort of grim-faced jury of white-coated pundits and has to make a speech and do a bit of mental arithmetic. It is stressful, and you can see that whether you're resilient or burnt out, that acute stress is associated with an increased level of IL-6 production by circulating monocytes, and the level of increase, the extent of increase following acute stress is increased in the teachers that were more stressed, more burnt out to begin with. So it's just an example of what I think is going to be a very interesting area in the future. How does social stresses play into the biology of depression through the immune system? And in the book, I put this, it is an artist's impression. So this is a very sort of cartoonish, high-level way of thinking about it all. You know, the inflammation causes changes in the brain, causes changes in mood that we recognize as depression. Depression may itself increase our risk of social stress, or we may encounter social stress for various other reasons, and that is one amongst a number of possible causes that drive the inflammation in the first place. That looks very childish, but it is based on some solid science. And this is not something that we're going to be able to, I'm not going to be able to talk to in detail right now, but just to give you a sense of what this looks like based on animal experiments, here's the lightning bolt of stress coming into the animal's brain, activating a nerve cell, which, amongst other things, sends through the sympathetic nervous system a signal to the immune system, the bone marrow and the spleen, causing the release of relatively immature and angry monocytes into the circulation, where they may extravasate from the blood into the brain at particular brain regions where there is local expression of chemokines to encourage immune cells moving from the blood into the brain. So this kind of circuitry in animals is beginning to be quite well understood. We need to obviously think hard about how we would test those kind of models with equivalent precision in humans. So I'm going to assume now that you're completely content that inflammation and depression are very commonly occurrent, they're very commonly associated, that there is a causal relationship, or can be, and that we're beginning to see some mechanistic evidence for how exactly inflammation could cause depression, and indeed where that inflammation might come from in the first place. But there's still, under the hood of causality, there's a different kind of question altogether, which is not so much how, but why. Why would you become depressed as a result of inflammation? What could possibly be the sense in that? And of course, biologically, it has to go back to Darwin. There has to be some survival advantage in a depressive response to inflammation. And there is a theory, it's an evolutionary theory, like many, it's a bit of a just so story, that our caveman, when he was injured on the ancestral plains, yes, he had the classical local signs of inflammation, but look, he's a bit depressed as well. His behavior may be changed. You know, he maybe withdraws from the rest of the tribe, he's less energetic, he conserves energy to fight the infection, his appetite is changed. You can make up a story that those kind of behavioral responses to an infection or a trauma that might have been driven by the immune system could have been advantageous in terms of this individual surviving from infection or trauma at a time when infection or trauma would have been amongst the major causes of early death. Now, how do you test an evolutionary theory like that? Because it's certainly not the first evolutionary theory of depression. I doubt it'll be the last. Well, one way that I like to think about it is in terms of genetics. So if it was true that we had evolved a behavioral response to infection that was mediated by the immune system, that had some survival advantage in the distant past, but might not be so advantageous to us now, then I would expect that the genes for depression would include genes that were specialized for immune function. And one of the exciting things I think about the era we're living in is that we are just beginning to see the genetics of psychiatric syndromes poke its head above the statistical noise. So this is a Manhattan plot. This is showing where in the chromosome, where in the genome, stretched out along the horizontal axis, where are there specific associations with major depressive disorder. And these data were only published roughly this time last year. There are 44 genes on that plot. They're all risk genes for major depressive disorder. They each have very small effect. But it's still interesting to think, well, what's the evidence that any of these genes have immune functions? And I don't know the answer to that for sure. But I think there is some preliminary evidence that this gene set is enriched for immune functions. I'll give you one anecdotal example. If you just take the top hit here, it's a gene called olfactomedin-4. If you look it up on Wikipedia, until it was discovered as a risk gene for depression, its main claim to fame was that it controls the inflammatory response of the gastric mucosa of the rat to infection by H. pylori, Helicobacter pylori. Now, I'm not saying that proves the evolutionary theory, but that kind of genetic evidence is compatible with an evolutionary story, in my opinion. That the risk genes for depression in an animal setting turn out to be important for controlling the gastrointestinal response to infection. Much more work to do there still, but the genetics is exciting. So what? So, yes, maybe you're convinced that inflammation causes depression. We can work out a sort of mechanistic explanation for that. We can understand where the inflammation comes from. We can link it to risk factors for depression like stress, obesity, that we've recognized epidemiologically for many years. We may be able to link it to the genetics and evolutionary theory. But how is this going to make a difference to the problem I started with, which is that depression's on course to be the single biggest cause of medical disability? A third of patients offered treatment with existing options are not responding. How can this help us discover new treatments? And here it gets a little bit more speculative. I wish I had a kind of complete answer, but I don't at this stage. But my hope is that this will take us in a slightly different therapeutic direction. So instead of patients coming in to the clinic and asking, being asked a few questions about their mood, and then we offer them a one-size-fits-all SSRI or CBT, maybe we can get to a place where you've got a clinical syndrome, a syndromal diagnosis of depression, and then there's an investigation of possible causes, including perhaps a blood test or biomarker for inflammation. And if you're inflamed, that might lead to a specifically anti-inflammatory intervention. And if you're not, then there are other treatment options that might be available to you. That kind of personalized approach, where we're doing our best to identify causes of depression and treat the causes of depression rather than offering the same treatment as a sort of symptomatic relief to everybody with the same syndromal diagnosis, I think is an exciting destination. Now, how far have we got in terms of demonstrating that anti-inflammatory drugs can have antidepressant effects? And this is yet another meta-analytic forest plot. And these are the data that I introduced earlier. These are clinical trial data from Janssen and GSK, 18 trials in total. None of them are for psychiatric disorders, but they all the trials included a few simple questions about mental state as a sort of secondary endpoint or a safety endpoint. And in this meta-analysis, we went back and we meta-analytically looked at the secondary endpoints. So essentially, we reanalyzed the data as if they'd been designed to test whether there was a treatment effect on depression. And we found that there was. Effect size is about 0.3, which is about the same as the grand mean standard effect size of existing antidepressant drugs. And for some mechanisms of action, that was even stronger. The conventional Cartesian skeptical response is, yes, okay, maybe they're getting better, maybe their mental state is improving, but that must be because they're feeling better. Their physical state's improved. It's not a direct effect of the treatment. It's a sort of secondary effect via physical health improvement. And that's a difficult alternative interpretation to completely discount, because these trials were not designed for that purpose. But we tried in various ways to statistically control for physical disease symptom change. We also repeated the whole analysis using just a subset of patients that had not responded in terms of their physical disease to treatment. They were still as arthritic as they had been, but there was nevertheless an improvement in their mental state. So I think this is compatible, it's circumstantial, but it's compatible with the idea that anti-inflammatory drugs, at least in comorbid depression, can have antidepressant effects. But what about major depressive disorder? Again, crossing that nosological divide. What's the evidence that anti-inflammatory drugs could be perhaps useful in adjunctive treatment of psychiatric depression rather than medical depression? And here we will need biomarkers. We will need biomarkers to avoid failing again. And I say that with complete confidence because this is data from the first and still one of the best published trials of an anti-inflammatory intervention in major depressive disorder. This is the anti-TNF antibody in patients with depression. You can see at a glance that there's no meaningful difference in symptom severity at the end of the treatment period. So this was a failed trial on its primary endpoint. But when the authors went back and they looked into the data in a little bit more detail, they found some evidence that there was heterogeneity within the patient group. There was a variability in terms of baseline CRP. Some were more inflamed than others. And the patients that had higher baseline CRP were those that showed a greater response to depression. What that says to me is that we are going to need to find biomarkers that we can use to predict which patients are going to respond, and we're going to need to use those biomarkers prospectively to stratify patients that go into trials. And those biomarkers, I don't think, are going to be a single protein. I don't think that we should be looking for a single sort of smoking gun, if you will, that's diagnostic of inflammation. More likely, I think, will be some kind of network of gene co-expression. And this is data from a microarray study of patients with depression showing that it's not just one gene that shows expression changes. There are a cluster of genes specialized for innate immune response that are increased in their expression in depression. And incidentally, there are also a number of genes associated with the adaptive immune system which show reduced expression in depression. So I think that is where the future is going to go in terms of biomarkers. I think it'll be some sort of cell-specific gene expression network, would be my guess, for the sort of thing that we need to predict which patients are going to respond. Now, I've got plenty more data slides which I'm going to slip over. I just want to say two things very briefly before I finish, hopefully with time for questions. One is I am focused on drug development, but I know that there will be people in the audience that don't think that drugs are necessarily the right solution for depression, certainly not for all patients with depression. I want to make the point that the basic neuroimmunology idea, the idea that the immune system has something to do with the nervous system and may have something to do with stress and other factors that drive depression, does not mean that therapeutically drugs are the only game in town. This is one example of a non-drug intervention, vagal nerve stimulation. It's been licensed for depression since 2005 in the States. Nobody really knows very exactly how it works, but one fascinating new piece of physiology that's emerged since these stimulators were licensed for depression is the so-called inflammatory reflex. We now know very clearly that if you stimulate the vagus nerve, one of the things that happens is you damp down the inflammatory activity of macrophages in the spleen. So this is an anti-inflammatory, there is an anti-inflammatory sort of, well, it's a homeostatic circuit involving the vagus, and the stimulation of the efferent limb decreases peripheral immune activity. Maybe that's why VNS works in depression, I don't know. Or maybe you could invent a biomarker that predicted which patients were more likely to respond to VNS. So that's one point, that please don't discount the science because you think it implies pharmaceutical or pharmacological therapeutics, because there are other ways of controlling inflammation apart from drugs. The other point is it's not just about depression. So this is the first patient with Alzheimer's disease, and these are some of the sort of clumps of peculiar material that Alzheimer saw in her brain. And one of the things that we have increasingly recognized is that these abnormal proteins, aggregated tau and amyloid, are recognized or may be recognized by the immune system as antigenic. Their aggregation changes their physicochemical properties in a way which makes them look unfamiliar to the immune system, and they attract the attention of microglia, which stimulates a local inflammatory response, may contribute to nerve cell damage, may accelerate the progression to dementia. So there's a lot of interest in inflammatory interventions around neurodegenerative disease, as well as mood disorders and other psychiatric disease. So with those two thoughts, I'll come to a close, and I'll remind you of where this all started, or where I started the talk anyway. We could be on the cusp of revolution. What I mean by that really is that this science contributes to a reformulation of the Cartesian settlement of Western medicine. It makes us think differently about the relationship between body and mind. It won't be televised. That means it's going to take a long time. I think this is going to take generations probably to work its way into practice completely. It's going to be a slow burn. I might be wrong, but I do think it has already begun. And with that, I thank you for your attention and happy to take a few questions.
Thank you, Ed, for a wonderful talk. Any questions?
I said I have 2 minutes. Neuroimmunology could be sort of hubbed within the brain, perhaps one of the places. I'm not a dualist as such, but it always looks like we're describing how the mechanism is working rather than how on earth does a thought generate a physical change. So is that something that's being looked at instead of just interleukins? Has anybody looked at that?
Yeah, I'm sorry, I'm a bit deaf today.
Oh.
So I'm not
The
sure.
first part of the question was
the
about...
question was how does the hormonal axis interact with this, especially things like prolactin?
Right. Well, that's quite a deep, important question. But I mean, I think the hormonal axis that looks to be most relevant to this is the HPA axis. It's the cortisol signaling, which of course is stress-related, and cortisol you can think of as part of the brain's anti-inflammatory system. But there's quite a lot of data. Carmine Periante's published quite a bit of this. We've seen echoes of it in our own work, that the inflammatory gene expression changes, for example, that you see in depression are negatively correlated with changes in the glucocorticoid receptor gene. So I think that's one very important point of connection. How does inflammation relate to HPA axis activation?
Leading directly on from that, the archetypal anti-inflammatory drug for autoimmune conditions, vascular disease, are exogenous steroids. But prednisolone is thought to be associated with depression as an adverse effect.
So I think with steroids, there is a sort of, there's a story that acute single-dose steroids are often mood-boosting. More chronic exposure is more likely to be either depressogenic or, in fact, psychotogenic in some cases. So steroids are not going to be the anti-inflammatory mechanism that we're, I think, going to use for antidepressant purposes. It's an interesting question why they should have those paradoxical effects. Does that refute everything I've said, or does it suggest that, in fact, particularly with chronic exposure, steroids have more complicated effects than we might imagine? I'd obviously prefer to believe it was the latter explanation. But I think the mechanisms that people are interested in are, for depression, a lot of people are interested in essentially repurposing anti-cytokine antibodies, because there's quite a lot of evidence that they have these mood-boosting effects in comorbid depression. None of those antibodies will, unless they're administered intrathecally, which is not going to happen, none of those antibodies are going to get into the brain in significant amounts. So I think it's also going to be important to try anti-inflammatory drugs that have good brain penetration. And from a pharmaceutical perspective, there's a sort of a sort of unintended roadblock here, which is that often drugs are screened out of development if they've got brain penetration, because people will think, well, that's only going to cause problems. Getting to the brain is going to change mood adversely, for example. So it's quite often the case that particularly immune and inflammatory drug development programs, they'll be full of drugs which hit interesting targets, but they don't get into the brain by design. So we may need a next generation of drug discovery, which is going to give us drugs with high brain penetration as well as the capacity to hit more selective targets.
We have to vacate this room soon, so we're on the last question.
Hi, Luca from Cambridge. Very fascinating talk, thank you. In terms of, functional neuroanatomy of the inflamed brain, do you think we can do more to try to understand where, inflammation or CNS, central nervous system inflammation, is localized? Because I wouldn't imagine that, general inflammation, spread all over the brain will cause inflammation. I mean, I'm thinking about people with multiple sclerosis. Clinically, we know that even if they got, a sort of highly severe disorder, in motor terms, they might not be depressed.
Yeah.
Other people with multiple sclerosis early on might end up being very depressed.
Yeah.
Still, both of them have got a classic CNS inflammatory disorder. So what do you think we should do in terms of understanding better the functional neuroanatomy of microglia activation, for example?
Well, so you can approach that question in animal studies, and people have done. And you're right that it is, for example, the inflammatory response to stress in the animal brain is not diffuse. It's local. There are certain particularly stress-responsive brain regions, and that's where the chemokines are expressed that attract immune cells in from the circulation.
Local difference in the blood-brain barrier, for example, biologically. I'm just wondering why.
That's what chemokines, you can think of chemokines in this context as sort of selectively opening the door of the blood-brain barrier. So they will facilitate immune cells to stick to the blood vessel walls and then squeeze between endothelial cells. Now, obviously, we can't look at that in humans, but what we can do is these sort of experiments. This is just a very simple resting state fMRI experiment where we're looking at changes in functional connectivity in the brain in people without depression, people with depression but with low levels of inflammation, and people with depression and high levels of inflammation. And I think you can probably see that there is a progressive progressive decrease in functional connectivity strength in the depressed and inflamed people, particularly in these blue areas, which you may recognize as components of the default mode network. And that seems to be the case based on that is a sort of a reasonably well replicated finding already, that CRP as a measure of peripheral inflammation is correlated with changes in functional connectivity, particularly in the components of the default mode network in cortex and subcortical nuclei. So I think those are going to be the bits of the brain that are most inflammation responsive, and that's encouraging because those are bits of the brain that we know are important for mood disorders already.
Thank you, Ed, for a wonderful talk. I could see loads more hands. Professor Bullmore's going to be doing a book signing now, so for less than £20, he'll answer your question, I'm sure. Just one more announcement, which is that those of you who have paid for the dinner, it's at the British Library, not the British Museum, don't get confused, and there will be beef stroganoff and a mariachi band. How could I advertise it better? Well, with a video. Can we play the video? This is Last year was a Cockney Knees Up, this year a mariachi band. We're still waiting for Professor Butler to better last year's performance.